to listen to me talk about health equity and cultural responsiveness a bit this evening. But before we get to that, a couple little housekeeping bits. I work for the University of Regina. I do not have any conflicts of interest to disclose at this time. And I also want to acknowledge that I'm coming to you today from Saskatoon, which is in Treaty 6 territory and homeland of the Métis people. I start every presentation I do, particularly about these topics, with a land acknowledgement. And I really think it's critical just to sort of be aware of the relationship between inequities and displacement from land, disconnection from lands, but also the significance that land can play in reconnecting people and in fostering that sense of healing, which, you know, when we're talking about palliative care, certainly means something different than typically when I'm presenting to healthcare providers. And so I'll tell you a little bit about me as I go through the presentation, but certainly my background is in social work. I'll tell you that as we begin. And I am born and raised in Saskatchewan. And most recently, before working for the University of Regina, I worked in our provincial health authority as a knowledge translation specialist focused on health equity and cultural responsiveness. And so now I'm a faculty member in social work at the University of Regina in the Saskatoon campus. So learning objectives for this evening, this is really just dipping a toe into topics around health equity. These are very broad topics, but my hope is that by the end of this evening's session, you'll have a sense of, you know, how I have articulated health equity and cultural responsiveness, and we will talk as we go through this session about how there are very different ideas about these things. And really, I don't think there's a right or a wrong idea. It's sometimes context specific or discipline specific, but my hope is you will take away some of this content in a way that allows you to apply it in your program or your direct practice when we're all done. So this quote from Dr. David Roy really hit me when I was preparing for today. I'd read it before, but the question of how do the poorest of the poor die? Do we really want to know? That knowledge could be very disturbing, loaded as it might well be with imperatives for action. And so often in my work, which has included bits of palliative care work over the years. I've primarily, most of my social work has been in the areas of working with people who are street involved, living with HIV, and who have substance use and mental health issues. And often there's a lot of sort of need around end of life care, but not a lot of support available, not a lot of practitioners who you know, provide that specific service or whose services are available to a lot of the folks that I was providing support to as a social worker. And I certainly know there have been, you know, outreach-based teams, specialist palliative care teams pop up over the years across the country, and we're going to talk about some of those tonight. But the reality is most communities and most people will not have access to those types of services. So I'm a passionate advocate for how, you know, really trying to figure out how we can all incorporate an equity-informed approach and a culturally responsive approach, no matter whether we're a family physician or a nurse practitioner, maybe you're a mental health therapist, a physical therapist, maybe you're a volunteer. And how can you take these ideas and actually use them to hopefully expand access and improve experiences of care? And often I'm talking about improving outcomes of care as well. And when we talk about palliative care, of course, our outcomes and our goals are different. But really it is, how do we make sure that all people have access to good care at the end of life, and how are able to have you know, the best life they can, but also the best death they can. So when I talk about health inequities, really just to make sure we're all on the same page, how I understand this is that differences in health, and I consider health a very broad category, not just physical and mental health, but our collective health, our well-being, and so on. But differences in health between population groups, whether those are social, economic, demographic, geographic, and we know there will be differences between groups of people and between individuals, but we're talking specifically about differences that we see patterns in that tell us these differences are unfair, they're avoidable, and they're systemic. And so being able to then think about, if these are avoidable, how do we actually do the work to try to shift our practice, and hopefully then shift people's experiences of health, but also experiences of health care. So when we talk about health equity, then this is really about how we incorporate the idea of fairness into our understanding of health, that there is not a level playing field when it comes to health, much like there isn't a level playing field when it comes to a lot of parts of our world. And many of us are aware of those, gaps, those differences. Some of those differences are to be expected. So we're talking about the ones that are, we can say that's not fair. An example that I often use when I'm doing this work in Saskatchewan is that around Saskatoon, where I live, when we look at the people who are most advantaged, so by most advantaged, we would mean have the highest education, the most stable income, and the most stable employment. So they're full-time employed with a stable income and an adequate education. Compared to most advantaged, least advantaged, we have a gap of about a decade in life expectancy. And that isn't accounting for any other factors yet. So when we add in ethnicity and race, we see that gap widen, right? And so that isn't a fair difference. That's based on, if you make more money, you're healthier. If you have better work, you're healthier. And we have lots of evidence from around the world that has told us this for decades. And so in order to disrupt these sort of gaps in health, or to remedy these unfair conditions, we really need to focus on everyone, and we need to think about, who are we not serving well? Who are we not getting to? Who's not getting to us? And certainly the experience of the pandemic has pointed out a lot of those health equity issues. Access to technology and communications devices, which now is a basic need in most people's lives, to access healthcare, to access education, to access even basic things like groceries. And so really, we couldn't have planned a better way to illustrate health inequities than a global pandemic. Sadly, though, in our response to this pandemic, a lot of it has been just kind of scrambling to figure out, how are we continuing to function when a lot of the ways we used to work aren't working right now. So adding in this consideration about equity is, a piece that has been more challenging, I think. And I'm going to speak to that a little bit this evening. So one of the pieces I often point out is, when we talk about health and well-being, or when we talk about quality of life, very typically, especially in health and in the health sector, we focus a lot on individual behaviors, whether people are doing things that promote health, or perhaps foster conditions where health issues arise, where people's health is poor, and healthcare services, including access to health services, the variety of health services, and what's covered, what's not, what's available locally, what's not. So of course, being in Saskatchewan, we have a very large rural and northern population, and it's spread out, which means healthcare providers and healthcare services are accessed often in very different ways than they are even here in a smaller city like Saskatoon. So of course, in your context, depending on where your practice is situated, healthcare services look different. But what we know from the data is that a person's health is actually determined as much by their social and physical environment as it is by their choices or behaviors and the health care they get. So I just wanted to throw this out there, because it's a good reminder that, we might not be specialists in housing or food security or other sort of more the social issues. However, those things are very much related to and impacting the outcome of our service when we're a healthcare provider, whether a person's changes in their individual behavior is enough to improve their health. If you're living in really poor housing or you're homeless, you can change a lot of individual behaviors, but still be very unwell or still have a lot of sort of negative or adverse aspects of your health status, that often we don't really attend to those particularly well in healthcare. And there's often this sense, oh, that's over here with the social service providers. That's their job. The reality is, when we don't have good social supports, when people don't have safe neighborhoods, good housing, clean drinking water, and so on, where does it end up? Where's the trickle down land? Health, right? People are dying sooner. They're living their lives with more illness. They're struggling more with things like mental health. And these, of course, impact other systems. But by and large, the system that ends up paying the bill for that is the health system. And so these are all health issues. And I think it's important that we begin from that position. So this is an image that was developed by my former employer, the Saskatchewan Health Authority. And it's one you've likely seen a variation of. They come around quite regularly. These attempts at sort of capturing visually what we're talking about when we talk about equity. So the story I like to tell with this visual is this, that if we look at the equality side, right, we have three people, three different needs, they're three different heights, right? So you have the tall person, they don't even need to fully extend their arms to reach that apple, which could be their best health. And in this case, could also be good end of life care, right? It's within reach. So these would typically be folks who would be described as having more advantage, more access to resources, better able to maybe pay for things like private care, have access to transportation to get to appointments, communication devices to stay connected to support systems, those sorts of things. So it doesn't mean there isn't, work involved or that it's not stressful. What it means is those things are within reach. Then we have person in the middle. Well, if they stretch their arms out, they're probably going to touch that apple, so they're close, right? And maybe they can jump a little bit, or they have really long, exceptionally long arms, and they can just grab that apple. Maybe they have a really dedicated group of friends who come by every once in a while and give them a boost. But generally speaking, with a bit of work, a bit of support, these are folks who can achieve that sort of good life and perhaps good death. Then we look at the shortest person, and this isn't at all a commentary on short people. This is someone, though, who, in order to reach that apple from that one little crate they're standing on, they will need to either be really gifted at jumping, have extra long arms, have a very dedicated group of friends, family, and other supports who hold them up, probably almost all the time, to reach that apple, right? The challenge with this is what we often do in our health system and in other settings is we point out these folks who've managed to pull together the supports or, stay connected to the supports they need to reach that apple, who maybe are exceptional in some way. They're gifted at jumping or they have really long arms. And we point out those folks as a success story of our system. And what we're doing unintentionally is we're saying, if this person can do it, so can you. If this person can cobble together the support network they need to stay well, so can you. And the reality is we're missing the piece of the structure underneath, where the system is providing the same support, the same service to every single one of these people, when they clearly need different things. And so equity is about shifting the work off of patients, families, and communities and into the system, not necessarily onto providers directly, but into health services, so that we can adjust services to better reflect the needs of the people we're supporting. And so that's a really important distinction to remember. And so, yes, that might mean we need to redistribute resources or an influx of resources. Wouldn't that be cool? I doubt it'll happen, but really being intentional about, is this that this person isn't, maybe not adhering to their plan as well as they could? Or is it that the supports underneath aren't adequate to actually allow them to do that? And so we see, of course, people who are facing multiple social challenges in life, having physical health challenges, maybe mental health as well, perhaps also feeling isolated and struggling with that community connection, they probably will need more in order to come up to that place where they have access and can attain that experience of good health, which includes good end of life. So certainly people who live in poverty and who are otherwise made vulnerable by structural conditions, so that's what I was just talking about, are almost invisible in modern day hospice and palliative care. And this is from an article written by a researcher who is part of a team in British Columbia, and there's a link to their team in the resource list on the slide deck, where they are really looking at integrating equity into palliative care. And so what they have found in their literature review and their environmental scan, and then in their work with some of the outreach teams, is that we often don't do a good job of even capturing those experiences because people are dying in shelters, or they're dying in back alleys. In Saskatchewan, recently we had someone die from exposure, from freezing to death. It was minus 56 here one evening. And certainly in a lot of cases, in my experience in HIV, this was very much the case, is that we actually weren't often getting folks to the point where they were needing palliative care because they were dying of overdose or violence, or they were dying by suicide, and so on. And so there's certainly been a shift again, I think, and in different parts of the country and different parts of the world, we see this look different at different times, depending on what's going on. So what's happening with COVID, what's happening with things like HIV, what's happening with access to support, where people are at, or are people needing to come into us to get what they need. And so what you're seeing is often, though, the very motivated, I often describe folks as the motivated elite. If people have to come to us, we often see just the tip of the iceberg, that lots of folks don't get enough of those supports, or don't have those exceptional abilities or characteristics that are going to allow them to get to us. So they are rendered invisible through those processes.
Erin, before we get too far away from the image that you shared, I just wanted to mention there are a couple of comments in the chat box. So one was that it's a very representative picture. And then the other is a comment that maybe the tall person worked lifelong and hard to get that advantage, in contrast with the short person never worked an honest day in his life to get any taller. Do we take away from the tall guy against his will to give height to the short guy?
I think that's an interesting question, and certainly one that comes up a lot when we talk about this. And I guess the question when it comes to health is, we live in a part of the world where there's been a commitment that all people should have an ability to reach their full health potential. And that, you know, how we get there is the main question. And so the question would be, you know, is health status something that should be tied to how much you make? Which at the end of the day is really one of the strongest indicators of health. Is if you make more money, you get more. So what about people who don't have an opportunity to make more money, or who face particular barriers? And one of the biggest challenges, I think, is, like, I've done a lot of work with chronic disease management programs. And one of the biggest challenges is people can't access some of those preventative programs, or they aren't meeting their needs. And so then they connect with the system when they're really, really sick, often come in through Emerge, or they come in when they might be palliative or heading very quickly to that point. And so the question is it wiser to invest in extending or expanding or reorienting services for folks who are on that end, because we're paying for it anyway? And I think that's, you know, like, these are folks who are coming in, and emergency room is their family physician, which we know doesn't work and we know isn't good care, but we also know it's really expensive. So being able to think about, like, we can think about it from a variety of perspectives, and the literature tells us, the economics tell us, that it makes good sense to shift from an equality-based approach to an equity-based approach. And the more the research comes in, the more we talk to people in communities, including health providers, the more we start to see that healthcare providers often feel more effective and are more satisfied with their work when they are actually addressing some of those barriers and challenges. It takes care of some of the struggle that many healthcare providers face in doing their work. So there's lots of areas of benefit. Certainly that isn't without challenge, and there aren't drawbacks. There are drawbacks for it, but all told, we can sort of take a variety of slices of this topic, and most of the time we end up coming back to a similar conclusion. I'm noticing there's lots of comments in the chat popping up, so I'll just pause for a minute in case there's anything else folks want to add on this.
Thanks, Erin. Thanks for addressing that and giving us food for thought there. There's a comment that that is there a way for us to increase a sense of community and social support for patients who can't access virtual health? So much loneliness, thinking of equity.
Yeah, absolutely. And I think the biggest piece is looking at what might be some of the informal supports that could be helpful for folks. One of the most amazing things that has come out of COVID here in Saskatchewan is we've actually seen, because folks can't come into our spaces often, there's been more creativity and outreach and trying to foster those connections. And we've had a few, street teams that are going up and down our streets and meeting people literally where they are at, which has been an interestingly surprising, I think for some people, benefit of a pandemic is you can't come in, but we'll go out. And I think the other piece is, Joe, not underestimating how valuable it is to have a connection, even if it's a sporadic one, even if it's an imperfect one, that we're acknowledging support might not be ideal and it might not be what we hope it could be, but it's still support. And that if we try to discourage or only go for the ideal, or really sort of push that too much, we may be missing an opportunity to acknowledge some other opportunities for support. Like even just going outside and saying hi to someone across the street is one way of, reducing isolation for folks. And we may think, well, but they really need this, and they do. And so I sort of take this harm reduction approach very broadly applied to all of this, not just substance use like we typically have, right? And so we can't maybe get the perfect thing for folks, but what can we do with what we have right now? And there's usually not a great opportunity. A lot of times people have exhausted all the resources. And then the question is, well, who do you see in your day-to-day? Who do you connect with, even if it's for a minute? The person who delivers your mail, the food delivery person, can they be part of, your sort of plan to reduce isolation? And that might be where we have to start.
Those are some great reminders. Yeah, great ideas just for, keeping things simple, but being able to connect with people in those ways. There's another comment now. Do you feel or see stigma on the part of some healthcare providers towards clients who are facing social mental health, isolation, and in quotation marks, non-compliance?
Oh, absolutely. And I love the sort of use the term non-compliant, right? That often we our system has created a way of making sense of how people interact with us, right? And so we assign meaning to what we see. So no-shows, non-compliant folks, and we've developed language to describe that from our perspective. And what in a lot of cases that has done, though, is it hasn't recognized that can be very stigmatizing, and that there are very often legitimate reasons why we're seeing people interact with us sporadically or not connect to care at the point where we would prefer they did, or not follow through with plans. So it can be as simple. I did a fair bit of work with one of our emergency departments, and And this came, well, we're an emergency room. What can we really do? We aren't going to be able to fix people's social issues in the emergency room. No, but when you prescribe something, do you ask people if they have coverage for that? Or if you're giving people a medication that needs to be refrigerated, do we ask, do you have a fridge that's safe to store this in? And a lot of the physicians and other healthcare providers were like, no, I actually don't routinely ask those questions. That it might be that it's not necessarily about, fixing the underlying social issue. It's how do we destigmatize some of that by acknowledging there are, very real barriers for many people. Are you able to get to this appointment I've set up for you? And if we don't ask, we run the risk of then being like, well, why the heck didn't you go to the appointment? I thought we had a plan, and then you didn't do it. And now you're back here again. Or now you're in more discomfort because you didn't do what we discussed. And I think so often that part of that is that sense of stigma. And of course, we also know that often there are disparities and vast differences in experience in terms of how people are understood when they do try to express needs. And so there's been a lot of dialogue, for example, over the last few years about people in pain and pain management, right? And I live with chronic pain. I have never, in the times that I have wound up, in urgent care or having to call my physician, I have never been met with resistance and a sense that people think I'm just wanting meds, even when that is exactly what I want. I want my pain to stop, right? And I've worked with possibly hundreds of people now over 25 years who that is what they experience, right? Is I'm trying to tell you I'm not okay and I'm not getting good care. Is that because there's a pattern? Possibly. Is it possible there's a pattern of that behavior and this person's pain is legitimate? Absolutely, right? And how does stigma then dictate their health-seeking behaviors or their care-seeking behaviors? And that certainly is, we see people get desperate, and then the pattern repeats and continues.
Thanks so much, Erin. It was really helpful for you to that you address those questions or those comments as we're going. And I think those are some really important reminders, that sometimes we don't know what we don't know, but it's really important to stay open and curious and to ask.
Mm-hmm. Yeah, and I think sometimes, and again, like I don't believe that healthcare providers go to work to provide poor care or to be discriminatory at all. And the health system is complex, it's under-resourced, and it is, I can say in Saskatchewan, it's frankly a mess in a lot of settings. And people are doing the best with what they got. And then I come along and say, do better, which I completely appreciate, the sense that seriously. One of the things that motivates me to do this, though, is that I also have been on the front lines and have seen the folks who, we get frustrated with because, oh, here we go again, I know what's coming. Or I just am out of ideas of what to do with this person because all the things I've tried just haven't seem to make any difference or do any good. And I see this as one way we can shift some of that. And it's not a magic solution. I'm not claiming at all that this is going to fix all the problems, but it is one way that we can see multiple benefits out of a shift that in some ways is not incredibly challenging to make, especially on an individual provider level.
So one last comment before you move on.
Sure.
Sometimes it helps to know the history of a person to have a better understanding of what is important to the individual.
Mm-hmm. Yes, absolutely. And actually later on in my slide deck, that's very much a question that I encourage folks to ask and to be curious about is, what's happened, what's gone on in your life that's brought you to this point? What would you like me to know? What's important to you? And depending on our role in our practice context, those questions might look different. or be, raised in different ways. But I think certainly getting that sense of what's the story here and being open to receiving this story with, curiosity, rather than going to, oh, I know where this story's going, I've heard it before. And being willing to just sort of accept the story without, I think sometimes there's a sense of, yeah, but do I know that's true or not? And the question I sort of encourage folks to think about if that comes up for you is like, yeah, but really that's not the whole story. There's another side. Is what would change about how you interact with this person if there was other information? And in some cases it's very relevant, and in other cases it's, and I can show up with curiosity and openness and kindness, and be willing to accept that this is not a complete story and there is more to it, but what can I do to give this person a good care experience right now? Which may include saying, and I can't really meet the need you have. I can do these things though. Yeah. Okay. So when it comes to palliative care, one of the really interesting pieces is this emergence of focus on equity in palliative care, which really excites me because I started my social work career with a real passion for palliative care back in the sort of early 90s, and particularly was interested in hospice care for people with HIV. Just as a point of interest, in case some of you aren't aware, Saskatchewan just last month got its first freestanding hospice. Some of that is because we have a relatively small population that's fairly spread out, but we've also just really struggled with having good range of palliative care and hospice care services in our province, and it's been a big gap for a long time. And we are, now that that's opened, we're moving into how do we serve people who fall through the cracks in our palliative care system, and who may be, dying in long-term care, in acute care, and could benefit from support at end of life, but also who maybe we're looking at the values and ideas and principles of palliative care being applied to folks who aren't, at the moment anyway, apparently at the end of life. And that was an interesting learning for me when I was coming to understand about palliative care. And I actually told Carl a little story that part of my journey with my own health conditions is I had exhausted sort of all of the treatment sort of management options, and was needing something to just keep me comfortable and able to have some semblance of quality of life. And one of my nurses said, so yeah, we may have to go the route of actually putting it on your record that you're palliative. And I was kind of horrified by that, because at the time I was maybe 40. It's like, I'm not palliative, I'm not dying. Well, we're all dying. But at the moment, I certainly want to live. And it was a great reminder. I knew that palliative care isn't just about death. We're talking about people whose interactions with us are more about quality of life, comfort care. And all of my career working with people who struggle with those unmet social needs, complex needs, all of those things, that really often is where they're at. They might not be there forever, but very much that is where they're at. And I think a lot of people who work in, whether it's street outreach or mental health and addiction services, those sorts of things, often are providing what could be considered palliative care without naming it as such. And I know lots of other healthcare providers do the same. And I think that's one of the pieces that we could take away from today is this idea that who's doing this work without it, being visible to us? Who needs this type of support? And can we see them? Do we know who those folks are? And so one of the things I encourage people to do is get curious and say, what do we know about the people in our community, the people in my, here we have health networks for primary care providers, people in my network, or the people in my practice, the patients I'm serving. What do we know about them in terms of how well they represent the populations in our community. Are we seeing a group of folks that somehow reflects the dynamics of our communities? And if we're not, who's missing? And these are really critical ethically oriented or equity oriented questions. One of the resources I'm going to have Carl send you is a equity lens guide, which has a really rich range of questions that can help us look at various aspects of practice. And they're applicable in any type of organization or service delivery setting or profession, where we can say, okay, how are we thinking about equity and how we communicate with people, right? And do we have a variety of options available? And if we only have limited resources, should we be prioritizing those resources in a way that might improve access or experiences of care for people we're not seeing or people who we know have poor outcomes? One of the challenges in a lot of places is the data is really kind of thin in that area. And I know in Ontario, there's been a really concerted effort to improve sociodemographic data collection that will help us answer these questions. Because really, that's often what it takes, is to be able to see, okay, our neighborhood has 25% immigrants and refugees who live here, and I see almost none of them in my practice, or almost all of the people who come to our program would identify as part of that population. What is that telling us? And what can we glean from who we're not seeing? And you can get into some really interesting conversations. And I think that's really the question when it comes to equity, is who are we missing? And in order to answer it, though, we really need to improve the data we have access to. And it may be the data is there, we just don't know who to ask to get it. Or it's just not presented to us in a format that's very usable. And I know health quality organizations are getting increasingly interested in looking at measurement and understanding outcomes of systems in these ways. And so I encourage everyone to just sort of think about, what information do we have? What do I need? Could I get that somewhere? And be open to whatever that tells you and what it doesn't tell us yet. And in Saskatchewan, certainly we struggle a lot with this. We don't have great data, and we're on a very long road to getting that fixed. But some of that's about which computer systems talk to each other and where data gets collected and entered and who has access to it. But it's also about educating and informing folks about, why would we want to know your ethnicity? Why does it matter? And it's really that equity quality question lived out on a patient level, is, shouldn't it not matter what race I am? Ideally, yeah. But we have so much literature and local data that tells us it is mattering right now, and not in a good way. That people are receiving poorer care, their access is lower, and their outcomes are poorer. And that happens all over Canada, in small communities, large communities. And it needs, in order to address it, we need to be targeting those inequities. It won't be resolved by accident. All right, so before I move on and talk a little bit about cultural responsiveness, any last sort of questions or comments about equity?
There's a comment here, Erin, on the topic of mental health. CMHA charges for mental health first aid and other similar information that should be circulated for free, considering 50% of people will have a mental health crisis sometime in our life.
Yeah. Yeah, and there are plenty of examples just like that. Yeah, it's a good one, right? Where it's how has information become monetized, but also support. And so one of the pieces that I spend quite a bit of time talking about is access to mental health support in the form of counseling, where if you have private benefits, you have access to counseling faster, more specialized counseling, longer term counseling, and it's likely that you're able to some extent, pick and choose the right counselor for you. Whereas if you're coming through our publicly funded health system, we have, in some cases, a 1 year plus wait. People are asked to limit their concerns to one issue that can be addressed in 6 to 8 sessions, and they typically don't get a choice of who they see. And so that is a very significant disparity there in terms of the type of care. And we know people who have unmet social needs often have unmet mental health needs, and often they're very complex. And so those are the folks who are being sort of diverted into that publicly funded system that isn't designed to meet their needs. And they could often, I think, benefit from a more robust system that hasn't been adequately resourced or designed to be accessible to that population.
Yeah, we have another participant though who notes that there are many more resources being made available for free as a result of the pandemic.
Yeah, and that's been one of those exciting sort of side effects of COVID. It's we're seeing that awareness, right? That people can't get this information in typical ways. People's socioeconomic status has been impacted by the pandemic in a lot of cases. And so there's been a lot of really creative thinking into going into how do we make these things accessible when historically they haven't been. And my hope is that when the pandemic is over, we don't just go back to the way it was, that there's some real potential in some of the strategies that even telemedicine, I mean, that addresses a geographic disparity in access to care, right? We are not just talking about, folks who are homeless and live in large urban centers or people with substance use issues. We're talking about people who lived in rural and remote communities who don't have the services nearby, who may have to go to great personal expense to access some of these supports, and may not, because of that, be able to access it all. So in a lot of ways, I think care may have improved, and I'll be really curious to see as data becomes available, and it's starting to come out around experiences during COVID. But my hope is that there have been some who've experienced better care. I also know there have been many people who've struggled even more.
Thank you, Erin.
All right. So the other piece that I always sort of take from health equity, very commonly, some of the greatest inequities are around race. And this is another area where there's really patchy data, and there were calls throughout the early days of the pandemic that we need to be collecting a basic set of sociodemographic data, including race and ethnicity data, to really fully understand who is being impacted in a more significant way by this experience of the pandemic, not to mention in general, right? And so, we have seen people who earn less money certainly were impacted in the sense that they may not have had access to sick leave. They are more likely to struggle to meet their basic needs if they have to take time away from work, whether that's for self-isolation or if they become ill. And so the disparity becomes fairly evident fairly quickly, that folks, racialized communities and Indigenous folks are overrepresented in the lower income brackets, and more likely, therefore, to be impacted by that particular health issue. And this is not unique to COVID. We have been seeing this on all sorts of physical, mental health, community health issues for a very long time. This is just a very interesting and exceptional experience that's illustrating that pattern once again. But when we talk about cultural responsiveness in care, one of the things that I like to point out is that many of us have been trained to some extent in cultural competency. I was certainly trained back in the day in a competency-based model where there was an emphasis on learning about other cultures, learning about when I was first learning, I really wanted to be better equipped to support First Nations and Métis clients I was working with. And I'm white, I'm a settler, born and raised in Saskatchewan, grew up on a farm. I'm about as Saskatchewan as you can get. And I didn't grow up in a part of the province where we actually had reserves around or high numbers of Indigenous people in our communities. So I really felt I needed to develop that competency. So I went to a class, and it was, effective strategies for working with First Nations clients. And so I went to this, and I'm like, I'm going to get me a diploma or certificate that says I'm competent to work with First Nations and Métis people. And this was quite some time ago, about 15 years ago. And we learned all sorts of interesting things like, avoiding eye contact. One of the things we practiced was handshaking, which I was given the feedback that my handshake was too firm and might be perceived as aggressive, and I needed to like ease up a bit. And so we learned all sorts of little tidbits about First Nations people. One of the interesting things is, though, I took my certificate and I went back to work, and I was working in community, and had a colleague come up to me and say, Erin, I got to tell you something, and don't get mad. Oh, okay. What did I do? Well, I was chatting with an elder and she asked me who you were. And I said, oh, well, that's cool. And she said, yeah, she asked me who you were by saying, who's that shifty white girl over there? And I was like, what? She called me shifty? Why? What was she talking about? She didn't even know me. And so I did get kind of mad. And it turns out this elder had noticed that when I was interacting with fellow First Nations people, I was not making eye contact, and I was, looking down, looking sideways, looking very uncomfortable, perhaps even a little bit shifty. And, I just looked really self-conscious, I think. And so thankfully my colleague said, let's go chat with her. And I was like, no, I don't need to talk to her. It's fine. It's fine. She is entitled to her opinion about me. That's fine. And my coworker, who is Indigenous, said, no, Erin, come talk to her. So we went and sat with this elder, and she was very lovely and quite funny, but also very direct. And she said, who told you not to look at me? And I said, well, I went to this class. And she's like, really now? You went to a class that told you not to look at me? And I said, well, we were taught that, like, and she said, when people don't look me in the eye, I don't trust them. And I said, yeah, but they told us that First Nation, yeah, some of my people, that's absolutely true. And for me, I don't trust you. And I was like, oh, okay, what am I supposed to do then? What's the right way? And she's like, there is no right way. And that was such a huge unlearning moment for me, that my great intentions and my eagerness to learn and to want to do the right thing had actually taken me to a place that hadn't really helped. In fact, could have been harmful. Thankfully, I had really lovely, trusted colleagues who were not afraid to tell me the word on the street about the shifty white girl who was standing in the corner trying to avoid eye contact. And yeah, I was young, maybe would take that information a little differently now, but I think it still holds true that even when several years ago we had a large group of Syrian refugees coming to Canada, many of whom were settled, well, throughout the country, but we had large numbers come to Saskatchewan, and we had big teams preparing for the health services that these folks would need and how we were going to coordinate care. And one of the things I was asked to do was provide a session about the top 5 things you need to know about working with Syrian people, which was a pretty much an impossible thing to do, other than to say, well, you need to kind of figure out each person individually, that there isn't a sort of rule book about how to work with Syrian people, just like there's no list of things to do and not do when you're working with First Nations people. And that really sort of illustrates some of the challenge that's been sort of identified with the competency-based model. So I like to sort of introduce folks to some other ideas around culturally responsive care, and just give people some food for thought on the limits of the competency model. It's not bad or wrong inherently. It's just quite limited in terms of how it can foster good care experiences for people who historically and contemporarily might be not trust the system, not trust healthcare providers, have had poor experiences and sometimes very, very harmful experiences in healthcare settings. And so, you know, the model we've got has taken us so far, but it's clear, I think, to most of us, there's lots more work to do. So we need to open ourselves up to thinking about additional ideas about culture and how culture matters in our work. So let's start with a really complicated graphic. So I'm going to point you to the big circle first. And so when we think about culturally responsive care, many of us have a level of cultural awareness where, you know, we understand there are cultures that are different than mine. And that's a thing. Often, you know, the word diversity is used here. Diversity isn't bad or wrong either. It's just a fact. It's a thing. And then people may, you know, advance or sort of evolve a bit into a world where they start to think about cultural sensitivity rather than just being aware there are others that are different than me. How do I be respectful of those differences? How do I treat others with respect, even if they're very different than me, than my experience in the world? And then we have competence kind of as an offshoot from there, where it's often about skill, knowledge, do this, don't do that. Here are the, you know, most common beliefs that a particular group has about health or about a particular health issue. And what I sort of introduce and hope folks can think about a bit, hopefully some of you have heard of this, is the idea of cultural humility. That we take that place of competence where we, you know, are trying to gain knowledge and skills to work better across cultures with diverse populations. And how do we actually understand our own cultural position and how that influences our practice and how others perceive us? But also, how do we come to a place where we realize it's okay to not know? And so when we're in that competence space, when we're thinking about cultural competence, it's often much like my experience was. I need to know more about Indigenous people and how to provide respectful care to them. With a humility orientation, it would be, I can never fully know all I need to know about Indigenous people because it's a very, very diverse group. It's not a homogenous group at all. And so I need to be open to the reality that every Indigenous person I am trying to support or serve is going to have a different cultural identity, a different cultural experience. The relevance of culture might be very different from one person to the next, and that I will not need to know all the things I need, you know, I thought I needed to know about working with Indigenous people. And so one of the most common questions I get asked is about, well, what about this group? What about that group? And the reality is a cultural humility approach says, you know, you're looking at a person and culture may be highly relevant to them. So we do need to learn and become comfortable talking about culture, maybe asking about culture. But we also need to be willing to accept if they say, yeah, doesn't matter right now. I just need my arms in a sling or x-rays or whatever. This is what's important to me right now. So it's that sort of willingness to say, I don't know your story, I don't know your experience, so tell me about it. And this approach also, though, leads us to a place where we're thinking about the bigger context, right? And all of these interlinked in the middle here are what we would call culturally responsive care. And if you look to the sort of right of that big circle, there's a little arrow out. And what we want to get to is a place where people's experiences of care are culturally safe. So those of us who are from dominant cultural groups, and I would say I am probably about as dominant as you can get, culturally speaking. I'm, you know, Canadian born and raised. In Saskatchewan, it matters a lot if you are fluent and very comfortable communicating and reading English, speaking, writing. Also, though I have white skin, I have a university education, I've worked in the healthcare system and so on. So my experiences of care typically have been quite culturally safe, not always, but they're pretty good. But when you talk to Indigenous folks, their orientation to the health system, their experiences of care are collectively and individually about as different as you could get from mine. And is that because I've been a better patient or worked harder on my health issues? No, no, it's not. Um, Very honestly, it's because of my position. I expect to get good care. And if I'm not going to get it, I'm going to pick up the phone and call client services and complain, or I'm going to ask to speak to someone's manager, or maybe I'll even write a letter to my whatever politician, right? An MLA here in Saskatchewan, MPP in Ontario. So this idea that culturally safe care matters, right? It becomes the template that dictates future health seeking and help seeking behavior for individuals and collectively for communities and entire populations. But it's also challenging for us because it's defined by the people we support, the people we provide care to. And so cultural safety isn't something we can just do. We can't create it. We cannot learn to do it. It is the outcome as defined by people accessing service or the communities surrounding our services. And so it's a variable that we don't get to control, right? So we only can control who we are in that space in the middle. The other thing I wanted to add, though, is there are a variety of practice approaches or philosophies of care that actually feed into and get the gears moving a bit more towards cultural humility, including trauma and violence informed care, because it recognizes the historical context of violence and trauma. And it identifies that people are adapting and coping, not necessarily that they're disordered or ill. It promotes voice and choice and collaboration, which are there to foster safety. So you can see sort of that connection. Harm reduction has some similarities as well. It's that meeting people where they're at with an emphasis on reducing harm and promoting well-being, letting go of a focus on an ideal or in the context of palliative care, shifting away from maybe curative to what's going to be the most accessible, the most beneficial, give you the quality of life that you want. How can we move you in that direction? And how can we treat you with dignity and respect and compassion, regardless of where you're at and what choices you make? And then there's equity-informed care, which again, there's equity-informed palliative care, equity-informed primary care, and some really great resources and research being done, resources developed and research done across the country. And there's, again, going to be links in the slide deck when you receive that. But this also, again, recognizes those structural factors that how services are designed and delivered does matter. And it does often reinforce disparities in health or gaps in health. That we're prioritizing equity-oriented measurement and goal setting in our healthcare services. So we're asking those questions: who are we not seeing? Which might tell us something about how culturally humble our services are. So an example of how this has come about in some of the work I've done in the past is there was a clinic that was working with folks in one of our, sort of middle class, maybe even upper middle class neighborhoods. And we were doing some of this work, and one of the staff said, you know what, I'm just going to say it. I don't know why we keep learning about this stuff, because really we see mostly like white families come in here. And there aren't many like non-white people in this neighborhood. So it makes sense that we see mostly white families come into our clinic. And so one of that person's colleagues said, are we sure about that? And so they all actually had varying ideas about the demographics of the community they were supposed to be serving. And when after the session, we actually pulled some data for them, and their community has 15% Indigenous households. And they were seeing less than 2% Indigenous clients and patients in their clinic. So what we found, Indigenous folks were driving all the way to the other side of the city to go to a clinic. That might tell us something about either whether people are aware of the local service. We don't know. We need to explore and be curious about that. Is it that people don't feel culturally safe in that clinic? Possibly. And that means we have work to do. But even if it's people don't know about the clinic isn't open the right hours. The other clinic has drop-in. I don't know what it is, but being able to really think in that equity-informed way can contribute to advancing us further along that continuum around cultural responsiveness. So are there any questions or comments so far about the culture piece?
There's nothing in the chat box at this time.
Okay, perfect. I have stunned you all into silence. That's my superpower. I love it. All right. So really, one of the things that we need to think about is that culturally responsive care is an extension of patient-centered care that includes just, what we've already been sort of exploring is how do we understand and pay attention to social and cultural factors in our work. Rather than, saying, well, I'm not a social worker. And often that's the sense is, well, I get it, Erin, you're a social worker. That's why you care about this stuff. I just need to focus on staying in my lane and doing my job, which is true. But as with the example of providing a prescription in an emergency room, that's not addressing any root social issues, but it is paying attention to social factors by saying, do you have the money to pay for this prescription that I know the government doesn't fully cover? Or am I aware if that's covered on our formulary? Maybe there's a different medication we could use that is covered. And am I able to take the time? And sometimes the answer is nope, can't, don't have the capacity. So then there might be some advocacy to do around the impact of having someone come through that experience of care and not filling their prescription, and which could be deadly in some cases, but also feeding into some of the other, bigger social and health issues we see coming through our systems. But this stuff also is not just about how we interact with patients and families, or the people we serve or that we see as our sort of population we're there to help. It's about how we interact and understand our communities and our colleagues. And there's such interesting sort of research being done right now and stories being gathered around experience of people who work in health systems, people who work in human service settings, and their experiences of feeling that they can integrate who they are culturally into their work. And does that mean that we're talking about our culture all the time? No. But often there's a sense that people feel they must sort of fall in line with this particular practice, and they might not feel culturally safe to be who you are. And we've certainly probably all heard stories of healthcare providers who experience racism directed at them from patients, families, and sometimes from colleagues as well. And that doesn't foster a sense of cultural safety either. And so that I think is really critical. Ultimately, when we shift away from competence and into humility, we shift where the power is primarily situated anyway. So cultural competence is about me as a healthcare provider. What do I know or not know? How can I apply that knowledge in terms of the care I provide? And that's important. But it's also possible, as I learned, to know about other cultures, Aboriginal or Indigenous or others, but I can still be experienced as unsafe or shifty, or not being person-centered, not being patient-centered, if I'm focused on what I know about you, or what I think I know about you, rather than being open to what you're telling me about you. And that's a subtle shift, but a really, really critical one when it comes to cultural responsiveness.
Erin, can I pop back in? Just
you betcha.
Wonderful. So a comment that this is a really worthwhile discussion. A mention of the graphic. It was referring to the graphic with the range from cultural awareness to cultural humility. And so that slide, how very helpful, what a helpful description that was. Also a comment with so much variability on how cultures express themselves I appreciate you teaching to approach the issue one person at a time with openness. Yeah.
Awesome. That's good.
Yeah, definitely. And the last comment here, oh, not the last one anymore. Okay. A comment, a group of us in our long-term care home will be working to improve cultural diversity, especially Indigenous people and LGBTQ+. We are looking to add something to the care plan that is more personalized for each individual with a more person-centered approach to care, specifically when palliative care and end of life comes into place.
Nice.
Yeah.
Good. And I think it's so critical to be sort of having these conversations, like, where does it make sense? And is it in the care plan? Is it in, you know, the move into long-term care, or is it in a referral conversation? But also being mindful that we're creating space for people to say, I appreciate that you asked me about, you know, the fact that, you know, I'm a member of the LGBTQ community. At this point, there isn't anything particular that I think needs to be added in there. And for some people, like, that has been an adjustment too, is when we add those things in or start asking those questions, it can be hard when people are like, yeah, not my biggest concern right now, or I don't really know what would help or what I need. And for us to be patient and just hold space, that might come out later. It might come from a family member. It might be this person doesn't trust us yet enough to share that, or they're not really sure what we're looking for yet because they have never been asked about that in a healthcare setting. It could be just, though, that other parts of their care are the important parts to them, and there isn't a particular cultural aspect that they really need to be addressed. But we don't know until we ask often, right? And especially until people become more accustomed, I think, to this being part of the conversation around our health, that our culture matters. But how it matters and when it matters and why it matters varies so much. The most liberating thing for me about cultural humility and sort of realizing that shift has been that I don't have to know. Like, the idea of having to learn about every possible culture that could come in the door is terrifying. And what if I misinterpreted that cultural practice? And so it also helps us balance out relationships, because we become a learner almost. And granted, we need to be mindful not to, you know, make it the job of our patients to educate us about, you know, their culture or their various needs. But it's also a time when we can say, tell me how you understand that in your culture, or you know, and particularly around experiences like understanding death, but also thinking about various parts of the experience, like mental health. I worked with someone who we couldn't really figure out, they kept showing up to their appointments and they were talking to us, but there wasn't a lot of insight or shift. And finally, one of my colleagues asked him a question and said, is there anything that you haven't told us that you think would be really important for us to know? And I can't believe no one had actually asked that directly. And he said, well, in my culture and in my language, there is actually not a word for what I'm going through right now. So other than coming to mental health and trying to talk about what was going on every couple of weeks, this person was actually in a community and in a home in their family where there wasn't even language to talk about what they were going through. And then we continued the conversation to realize that along with that came a different explanation for what they were going through, right? There wasn't a word for the mental health issue this person had, but there was a different understanding of what they were going through. And it was very profoundly spiritual and cultural. We hadn't really considered those things as really being significant. And once we went there, we spent more time talking about, okay, how can you feel supported in your home, by your family, by your community, in ways that feel okay when there's this gulf between your understanding and theirs about what's happening with you. And it turned out, I mean, his community believed he had evil in him, and that the solution was not accessing a counselor and taking medication. The solution was to be found in the spiritual realm. And so this was someone that we were trying to sort of help understand what was going on. And they were unable to actually share that experience with anyone in their life. So they were highly, very isolated, really struggling to reconcile the difference between what they were learning from us in sort of the psychoeducational sessions with what they were hearing and what they'd been taught their whole life, and having a spiritual crisis alongside a mental health crisis. And I think often we don't quite go there, and we expect, well, people will tell us if that's a thing, right? But the power that healthcare providers hold, especially for folks who come from cultural backgrounds where you don't question people in positions of authority, or where there's no trust or really shaky trust in healthcare, people often don't feel safe enough culturally. That's what cultural safety is. I can say, whoa, this is actually not even a thing in my culture, without fear of being told, well, that's wrong. Well, that's ridiculous. Well, your culture needs to really, get with the times, which was the fear of this man, that if he told us this, we would essentially say, well, then we can't help you because that is far beyond. And so this is what it's about, is we don't have to be the ones who know all the things. We can invite that from the people we're supporting. And that's been so liberating in my practice, that it's taken a lot of the pressure off. And I really just need to be good at connecting with people and being curious and inviting the story in. And sometimes it's in tiny little sound bites, and other times it's a big story. But finding the way that fits based on what role I'm in and what opportunities I have.
Yeah, I love that, Erin. There's so much in there, but I really love that piece about, not making it our patients' or clients' jobs to have to completely inform, but, finding that balance of asking. So in an open, respectful way. So in line with that, there's a comment, with respect to palliative care, I often ask patients if there's something I need to be aware of culturally that might affect their end of life journey. Sometimes asking them in that way is just the best way.
I love that. That is such a lovely way to sort of frame that, right? Because it might not be, sometimes we're looking really narrowly at things. And then we ask the question too narrow. And I like that just sort of is a very inviting way to frame it. Like, somewhere along your journey, this might matter for me to know this. The other thing I think is really critical when we're talking about culture is we often automatically go to ethnocultural identity or race when we're talking about culture. And the reality is we all have culture. Many of us, and myself included, might not have had to think a lot about culture. If we're part of, a dominant culture, we might say, oh, I'm Canadian, maybe, I don't know, my ancestors were this, but we don't really practice that unless it's the holidays or, a special occasion maybe. And so it can feel like we're culture-less, or we're neutral, culturally speaking. And that can make us very uncomfortable sometimes if we're in that place of, feeling like we don't sort of do culture much. And it can make us, it's not part of our life in a substantive way that we can kind of understand how it might impact. And sometimes that really is reflected in how we try to make the connection and maybe go too specific or too narrow. And sometimes it is, well, I understand my culture, but I'm not sure about others, which is really that humility, is how can I get to a place where I spend more time thinking about my culture than I do about others. And that doesn't mean disregarding other culture. It means realizing, yeah, the fact that I can go anywhere in our health system and know that there are people who speak the language I'm most comfortable communicating in, that's a cultural thing, right? And that matters. I have never had to expend a second of energy worried that I'm going to get somewhere and they won't be able to talk to me, or I'm going to have to force to use the little bit of energy I got to communicate with you in a language that isn't one that comes to me easily, especially when I'm distressed or in pain.
You've
right?
sort of
So,
just answered a question that's in the chat box, but I'm just going to put
oh,
it out there in case you want to like round it out
sure.
a little bit more. But it's, can preconceived ideas of certain cultures create hurdles to care?
You betcha. Yeah, absolutely. And I think that sometimes that competency model, that's one of the risks of it, right? Is it might create an idea or a sense that we know, but we can also do that from our own experience, right? Oh, well, you're the same as me. So I know. But also, what one of the other pieces I was going to say is that culture is more than ethnicity, right, and more than ancestry. For me, as a queer woman, that's part of my cultural identity. There's a cultural experience of being also, though, someone who was raised in a very rural community on a farm. There is a culture. And it's funny, in Saskatchewan, people are like, yes, we know what small town Saskatchewan is like. That's a reflection of a cultural understanding. Is it based on a lot of assumptions and a lot of generalizations? You betcha, which is why this is so important. But there's a common language that people tend to relate to and understand. And that can be as culturally significant to folks as their ethnocultural identity, or maybe their lack of sense of what their ethnocultural identity is. The other thing that can happen with culture is it can evolve through different life circumstances. So we often would talk about the culture of people who are street involved, that there is a code of conduct, a way of relating, a sense of values that are really, that's what culture is about. And it may mean if we don't understand it, or we don't create space for people to tell us when it matters and how it matters, we may miss a really critical piece of how people are seen and how people experience the world.
Thank you, Erin. That's awesome.
So really, and this is from an article that will also be, it's included in the reference list for the slide deck, that cultural competence puts the expertise in the hands of the health provider. They stay in that expert stance. And the cultural humility says, well, you're the expert about you and your experience of culture. So I'm going to defer to you on that to tell me what matters. And what matters today might be different than what matters tomorrow. And I think that's the additional part of openness and curiosity that's important, is being able to say, well, I know you told me yesterday, but remember, if that changes, that's okay. You can tell me, actually, today I've decided this is really important and you need to know and you need to do this or not do that. And there may be particular cultural practices or beliefs that inform care. And those are some of the more concrete pieces. Often, though, the way culture shows up is in these more subtle ways, in relationship, in things like how comfortable people are being vulnerable, and that may vary dependent on gender and for age and a variety of other factors as well that we need to sort of consider. So when we're looking at that outcome of cultural safety, ultimately it's about prioritizing dignity and respect, and really, which I think most of us are trying to do every day, but trying to think, okay, I have a sense of this interaction as being a good one. And I go to work and try to provide safe care that feels respectful and dignified to people. I'd say most healthcare providers, that would be an accurate reflection of their motivations going into their workday. However, we also know one of the number one concerns identified by patients and families about healthcare services is issues around feeling they were disrespected or their care was not dignified. Are those situations where there are various perspectives on that? Absolutely. But if we want to think about how do we provide the best care possible, we need to be able to open ourselves up to realize that what I think is safe and respectful and dignified doesn't always feel that for other people. And all of us have very likely had experiences in life where somebody was trying to make us feel better or make a joke or lighten the mood, and we didn't experience that as positive. So we all know it's possible that someone's intent and someone's assessment of what happened can be very different than how people experience that. And that's what happens in health. But the stakes are pretty high, right? Are people going to feel safe to truly tell us when they're in pain? Are people going to feel safe to say that was not okay, or you really need to know this? And so these things become critical ingredients that go into how we provide care. And the hope is that when we do these things, we will create conditions that foster cultural safety. We can't do cultural safety or learn it. And in a lot of ways, it's actually even really hard to measure, because if people feel culturally unsafe, they're very unlikely to tell us that, right? So they might say what they think we want to hear. They may not answer at all, especially if we go with a survey, right? Or if we ask directly and the care was unsafe, people might not want to tell us that. There's often a fear this could impact care in a negative way, so I'm not going to say anything. And that's one of the great paradoxes of this, is we ultimately need to build relationships so that we can say, you know, I don't know all there is to know about your culture, but also about your experience of care, that there's more to it than what I understand as well. There's another side to my story, and that we need to find a way to be open to those stories. And that is a challenge that is going to be very difficult, very complex, and require a lot of relationship building. And I think for especially large health systems, that is going to take a long time and a lot of persistence and commitment to get there. Any questions? Yeah.
Yeah, there is one here. It's a specific question, but do you have any suggestions how to provide care for a hoarder when it's unsafe to enter the home as a visiting nurse? Time is fairly new to Canada, and language is also a barrier, even with a translator.
Okay. Yeah, that's a really challenging one. And I think some of it is, okay, going in isn't safe. Are there opportunities to connect with folks by having them, is there a willingness to come out, to come to the door? Can we connect and start that relationship building and try to provide little bits of care in little bites? And sometimes that's the best we can get to right now. And certainly in working with folks with HIV, similar situations come up, right? As you know, it's not okay for folks to get into this house at the moment. There are other barriers, language, sometimes cognitive state, other, you know, sort of challenges that become a part of the situation. And then it's, what are our opportunities for connection? Can we find any way to connect, even briefly, even if it's not addressing a significant amount of the health issues or providing a really substantive service? Can we start creating connection that may open the door to a little more and a little more? And can we be okay if that door never really opens and still see that as valuable service, as important, as health promoting, and as success? And often that's the challenge, is it's like, well, we're not getting anywhere with this person. So it might be who in our community can provide a service that will continue to show up even when there isn't a big shift, when, you know, and there will be a line where a decision might have to be made about whether this person is safe to live in their own home. But again, if that relationship is built, that conversation might look very different than it would if it's like, well, if you won't let us in, or if you won't come out, then we can't help you. And I think sometimes it's also just how we show up when we do, or how we reach out when we do. So are we doing that with sort of, again, that sense that let's figure out something, or sometimes we're coming at it, and often out of necessity, with a sense that here's what I can provide you. And if the person is unable to or unwilling to engage in those things, then we're sort of, sorry, nothing we can do. And if we have room in between there somewhere, that's often where there's room for those relationships to develop. Is, can it be more than either or? Can we find a way in the middle of there somewhere to build some connection, which is certainly going to benefit, even if it's not solving, you know, the big issues and taking away some of those big risks.
Yeah, what I really heard you saying there, Erin, is like letting go of preconceived ideas of what health is, right?
Yeah, yeah. Which in all reality, I mean, I've worked in, well, our health system in Saskatchewan, largest employer in the province, with thousands and thousands of workers and lots of complex pieces of the puzzle. And I know it's not always feasible to practice in that way. We don't always get the support to practice like that. So then it might be, how can we advocate for the need, that we need to be supported to do this? This is a service that's worth providing, because it may prevent, it keeps us in there so we don't get called in when there's a significant, decline in health, or a big crisis happens, or, it may allow us to be more efficient, just in a different way.
Another comment before you move on. You spoke of issues that we know are happening where healthcare workers are feeling unsafe, feeling discriminated against, or facing racism from patients, residents. I'm wondering if there are any resources you're aware of that can support conversations or learning within a healthcare team about racism and microaggressions.
I will do some digging. I do have stuff stashed away on that, actually. But I appreciate the question, because I think it's so critical. And it's a bit of a tricky one, right? Because when we're there as a professional, we're there getting paid. It makes the expectation different. That should not mean that we have to feel culturally unsafe or unsafe in other ways, when we're at work. And that's always a bit of an interesting balance to navigate. But I think being able to have conversations with our teams, and prepare as best we can for, how do I respond if I overhear someone saying something? So how do we prepare our colleagues to be good bystanders, but also still be respectful of patients and families? And I mean, we can set limits respectfully. And certainly one of the most interesting moments of this was Saskatchewan, was very front and center in the news a couple of years ago with the murder of Colton Boushie, by a farmer not far from where I'm sitting right now. And the subsequent trial was very sort of front and center in the media. And we saw the fallout of that in our health system, where there were experiences of racism on the part of patients experiencing racism. We also, though, saw racism that was targeted at staff and healthcare providers. And one of the pieces of that was people feeling, okay, there was a family member who was saying something to me or doing something that was inappropriate, and none of my coworkers said anything. And what we found is people wished they could, wanted to, they just didn't know what to say. Is it better if I just say nothing and, come here, I need you for a minute, and make the situation end? Is it, what should I do? And so I think many of us want to help. We want to do the right thing. We just don't know how. And so I will do a bit of digging and make sure Carl gets some resources to include in the email out around the microaggressions piece and the experiences of healthcare providers around racism.
Wonderful. Thanks for that.
All right. So really the question with cultural safety is sort of the outcome of all of this, and, including one of the potential outcomes of an equity-informed approach to the way we see health, no matter what our role and no matter what phase of life we're working with folks in, is being able to create an opportunity for people to tell us, right? And that has to go beyond our usual ways of soliciting this information. That may require us to be pretty creative and resourceful, and sometimes that's just not in the cards. So then I ask people to think about, okay, are you going to have interns or practicum students or others who are coming through your spaces who may have the energy to do this, to explore how we create space for people to tell us, was that okay? Was that not? Are you hearing out in community that there are issues with the way this service works or the way this health facility is viewed? What can we do about that? And having that openness to exploring other ways of creating capacity to address this can be really interesting. I mean, my main job now is I work with social work practicum students, and this is the kind of thing that they often love to sort of explore and figure out. I've also worked with some amazing med students who are like, yeah, I want to figure out, how do we ask patients about culture in a way that's appropriate and respectful? How do we document that in the chart? Where does it go? Who's asking those questions, right? And so I think there are opportunities sometimes, and we can be thinking about, where are they? And if we don't see them, can we talk to colleagues and like-minded service providers and say, what are you guys doing? Do you have any ideas of how we can start trying to address this? So I really believe, just as I wrap up my comments, that health equity is everyone's work. There's often, I think, a perception that, I mean, I was an equity specialist, so obviously it's a specialized thing. I never used my equity specialist title because I felt it reinforced this idea that it wasn't something that just anyone could address. It had to be someone special like me. There was one of me in a health system that employs nearly 50,000 people in Saskatchewan. One. I am not going to address health equity in Saskatchewan's health system, or any other health system for that matter, by myself, right? So each of us needs to look at, what can I do in my little world that's something that's achievable, something that's accessible to me, something that maybe is going to benefit me in some way. That might be a hook that gets our team involved, or gets, you know, it prioritizes it a little bit higher on the list. What might help our clinic? What might help our hospice or our service to be more responsive, to feel more efficient or more effective at what we do? And so I leave you with a challenge. Give yourself a goal. Make it realistic, though. So look at a week from now, 6 days, 5 days from now, what can you do? So maybe it will be, you're going to share the recording of this when it comes out with some colleagues, or you're going to put this on the agenda at your next staff meeting. Maybe you're going to look up one of the links I include in the slide deck. Those are all steps towards integrating health equity and cultural responsiveness into your work. It doesn't have to be solving all the problems and, you know, sort of saving the world, because that's overwhelming, and it's not work that we can do alone. So where can you meet yourself where you're at, and your colleagues and your team where they're at, and find sort of reasonable little bites that you can take of this work, because it will continue to be there, and it is a long game. This isn't something that's going to change overnight. And so those little steps all help us head in that direction. So I used to keep a sign very similar to this slide at my workstation. And it was just the constant reminder, what can I do today or tomorrow? Even when I'm feeling overwhelmed and run ragged. And it might be a reminder that, oh, right, I actually am doing something because I went to that session last night, or I, you know, took the time to listen to a podcast on my way in to work today. And that's also about becoming more equity informed and culturally responsive. So any more questions, comments, examples, or stories from your practice that folks would like to share? So while there's a little bit of a lull, I'll just say, at the end of the slide deck, there are several slides that just have questions on them like this. And these are the pieces that I encourage you, if any of these questions really resonate with you or challenge you in some way, feel free to print this stuff off, or, you know, do a screen capture of it, or save it as an image file and make it your desktop picture, whatever you need to do. In our work, we often had these print-offs of these slides that we would put up on our huddle boards in our, you know, where we met for staff huddle, or we'd post them in the staff room, or, in the hallway, just as those ways of keeping this sort of front of mind, or at least somewhere in the mind, and it doesn't just be that really kind of interesting talk I heard once, and then I go back to doing things the way. So yeah, Tara, any questions or comments that have come up?
Yeah, so there's a comment about what an excellent presenter you are and what a great session this was.
Thank you.
This is. Yeah, another one that loved your presentation, Erin. Thank you so much. You're fantastic. Thank you for your positive and manageable approach. So yeah, also, and I guess that's what I'm sitting here thinking is like, I so much appreciate, you know, the call to action and the manageable challenges. I think like health equity is such a tremendously large issue, right? And without that permission to take bite-sized pieces and work with those bite-sized pieces, I think it's pretty easy to become overwhelmed and not know where to start and just become, you know, frozen by that, by the worry of doing something wrong.
Yeah.
So I think, yeah.
Thank you for that, Tara. I was just going to say, I really hope the other thing that happens during these sessions is that people go, wait a second, we're already doing that. Mm-hmm. You know, like we might not have named it as a health equity piece or a cultural responsiveness piece, but we do that already. We're doing good work because I know there's great work happening out there. And I know, you know, I don't have any delusions that I'm the first person to come out with this stuff, right? Lots of us have heard about these ideas and had these conversations. And so then maybe the challenge for those folks is, how do you inspire or support another team or another practitioner to, you know, sort of rise to the occasion and do some learning or some unlearning, or to maybe work together and support one another to start doing change on maybe a bit larger scale, because I think there's often this sense that this is so big that it's going to require, you know, a specialized team. And ideally, absolutely, that would probably be the best way to get her done. But we also need people who are out on the ground doing the work, connecting with people, to be asking themselves these questions and thinking about how can they make that shift, even if our systems or our organizations are not hiring a team of specialists to start doing this work in a more intentional and system-wide way. We can't wait for that to happen. And I hope it does happen someday, but we can't wait because people are dying while we're waiting.
Yeah, absolutely, Erin. And the comments just keep coming in. And I could see from all of them, like there are many thanks and much appreciation. So it's clear that people are feeling encouraged, encouraged and enabled and excited to, to go out there and try things, and have appreciated your perspectives here.
Great. I'm glad that pieces of this have resonated. The other thing I want to throw out there for folks is, if you're like, okay, I just want to talk to her about something specific to our team, feel free to fire me an email, or, look me up on LinkedIn if you're on LinkedIn, whatever, reach out, because that is certainly one of the things I love to do the most is, okay, what's the challenge you're facing? What's the, your context? How do we apply this stuff with you? And I'm available as a resource, and I, can connect you to other folks who can help you, maybe resources that I've come across in my practice. But yeah, if you have questions or would like to sort of consult a little bit with me, please feel free to do so.
Thank you, Erin. That's really generous. I'm sure you'll be getting lots of LinkedIn connections.
I'm just trying to bolster my followers.
Really. Yeah.
Yeah. All right, and if people are interested in some of the sources for some of the earlier content on health equity, there's also a reference list at the end of the slide deck as well, if you want to pick up on some of those threads too.
Yeah, and I'll put the post-session evaluation in the chat here again. I put it in earlier, but it kind of got
consumed
lost in
by all the comments.
All the positive comments for your presentation. So yeah, that was a lot of fun. It's Erin, Tara, and I all have a background in social work, so it was nice to have sort of a social worky edition of Thursday Evening Series, and yeah, it was a lot of fun. And thanks again, Erin, for sharing all your
absolutely
questions and
And if folks are interested in having a similar session or a sort of offshoot of this session with your team or your organization, just fire me an email. We'll talk. I obviously love talking about this stuff and get pretty excited at the opportunity to explore different areas of how these ideas apply in our work.
Awesome. That sounds great. Well, have a good night, everyone. And thanks a lot again, Tara, to you as well.
Thank you. Thanks for having me.
Yeah, there you are.
I really enjoyed the presentation. Thank you, Aaron.
Yes.
Yeah, thanks to everyone for taking time out of your evening to hang out with us.
Try and find that one specific action, as Aaron was saying, by next week.
Absolutely.
All right, sounds good. Have a good night, everyone.